The main conclusion is that the device improves exercise tolerance, exercise capacity in patients with heart failure with reduced ejection fraction. And that is important. The improvement is significant, and those patients suffer from dyspnea, and that can be improved, and the exercise capacity can be improved significantly. It also, and these are the secondary endpoints, reduced hospitalization from heart failure quite tremendously, and in comparison with prediction scores for heart failure mortality, it also reduced mortality. Main point, exercise capacity. CCM is a device-based therapy, and the device consists of an impulse generator which is implanted like a pacemaker, and it has 3 leads. One goes to the atrial septum for sensing, and 2 go to the right ventricular part of the interventricular septum. And it delivers a stimulus during the absolute refractory period, which is during the R wave, and this stimulus influences process in the heart like protein phosphorylation, which immediately increases contractility, and over a while the stimulus results in an alterated gene expression, and this new gene expression profile is more favorable and improves left ventricular function and left ventricular geometry, so it induces remodeling. It is needed because many patients with heart failure, also we have good drugs, still suffer. And there is a particular subgroup, this is the patients with a QRS smaller than 130 milliseconds. They do not qualify for a device like cardiac resynchronization therapy, and they can benefit from this CCM therapy. In fact, it was investigated in a group of patients with ejection fraction between 25 and 45% and a QRS below 130 milliseconds. FIX-5C is a randomized study which has been based on data from a previous study, which shows that patients with an ejection fraction between 25 and 45% may benefit particularly from this treatment. So 160 patients have been included. They have been randomized in a 1-to-1 fashion, optimal medical therapy, where there's cardiac contractility modulation, and then there was a follow-up, and then both groups, of course, were compared, and in this comparison we show the improvement in exercise tolerance measured by peak VO2, which is the gold standard, and also in Minnesota Living with Heart Failure questionnaire, so the patients do better. There is improvement in the New York Heart Association functional class, and also in this trial we already show that there is a reduction in hospitalization and a reduction in mortality. You know, a randomized clinical trial, this is a special situation because you have many of exclusion criteria. You optimize the cohort which you want to study, and the registry gives you the real-world data, which we see in the daily practice with our patients. And therefore the registry is needed, and we included 140 patients in the registry, and the follow-up was 3 years in total, 3 years for mortality and 2 years for hospitalization and quality of life. And what we observed in this real-world scenario was a significant reduction in hospitalization for cardiac reasons of 75%. How did we do this? We compared the period before the treatment with the period after induction of the treatment, and the event rate dropped from 1.2 to 0.35, which is a significant improvement. In the last guidelines, cardiac contractility modulation therapy was mentioned, and it said it may be considered in a subset of patients who qualify for this procedure. And I think there is much more strength now to this recommendation. I think one may really consider CCM in a patient in an ejection fraction range between 25 and 45% with QRS below 130 who would not qualify for CRT and who still has symptoms, and this patient has a good chance to significantly benefit with respect to this exercise capacity, quality of life, but also with morbidity, mortality significantly from the device implantation.